Welcome all to today's RCGP webinar focusing on primary care networks. A few months ago, these three little words hadn't been put together, and now the three big letters PCN have become part of our daily vocabulary.
I'm Alka Patel, GP and Clinical Fellow with the Collaborative General Practice Programme. And today I am absolutely delighted to have with us four very engaging speakers who'll be talking to us about their PCN journeys and the art of the possible. They'll be talking about clinical directorship, rural working, and the practical applicability of population health management. So if you have any questions along the way, do type them into the chat box at the bottom of your screens, and I'll be collating them for a Q&A session at the end of each presentation. Any questions we haven't been able to cover during today's webinar, we will answer in our newsletter, so just sign up to the online learning network at gpatscale.rcgp.org.uk. So now, just sit back and join in. And now we will swiftly move on to our final presentations, which is a double act on population health. So I'm introducing to you Dr. Steve Laitner, and he is a portfolio GP in Hertfordshire and a health consultant with a public health background. And with him will be Dr. Omotayo Kufeji, and he is a GP partner in Milton Keynes and also clinical director for his PCN. So over to you both.
So sorry about the headphones, but I thought that might give a bit better reception. So I'm going to have to be quite brief. I'm going to put my 5-minute timer on. In fact, it's already been on. And just to try and bring population health management to life. So as been said, I'm a jobbing GP, but I was also a public health consultant. And I think for the first time in my life, I felt that the population health approach to looking at care and the clinical health approach is coming together. We have to be careful, though, not to conflate public health, stroke population health with population health management. So I think population health management is very close to clinical care. The clue's in the title, talking about management. So it's not just about understanding of the different health needs in the population, but actually doing something about it. And I see public health and population health looking at the totality of the needs of the community. Population health management is more about targeting care to groups of individuals who share similar needs, and hopefully that will make sense as I go through the talk. Traditionally, I think we've sometimes used not always the most appropriate methods to stratify or segment the population. We've identified people just by their disease or by the service they're in or by their risk of admission to hospital. And what I've tried to do with my work with the NAPC and primary care homes, I'm very happy to make all these slides available to everybody, is to use a more holistic approach to population health management. So what I've done with my colleague, an old GP, a friend of mine, Mark Davies, and also with the NAPC, is created this very simple 3x3 framework to think about the different needs of the population. So essentially, we've got three big life courses. We've got children and young people up to about 25. We've got working age adults, and we've got older people. But of course, people aren't defined by their age either. So the other dimension is looking at the level of need of different peoples in our practices, in our communities. There are people who are generally well with an absence of any long-term condition, but maybe at high risk of developing a long-term condition by virtue of some risk factors. There's people who have some sort of long-term condition or long-term need, whether that be a medical one or social one or otherwise. And there's people who have multiple long-term conditions, putting them at high risk of becoming complex, having complex needs. And that's more about the interaction of multiple physical problems, mental health problems, social problems. So we think about frail older people, end-of-life, dementia, multiple physical problems, and working age adults, often but not always people with mental health problems, drug and alcohol problems, social problems, etc. So really quite big, high-level cohorts of people with different needs, and we can drill into the detail of those needs further. What we've been able to do is use some criteria that I developed with colleagues, which you'll be pleased I won't go into the detail of this, but essentially you can just use a GP system in order to identify those cohorts of people in the population. I'm up in Milton Keynes at the moment. I'm about to attend a primary care network of the Watling Street Primary Care Network from the Milton Keynes area, and we've used their data to populate this matrix that you can see here, essentially showing across the ages about 3/4 of the population are generally well, about 1/4 have some sort of long-term condition or long-term need, and an important but relatively small proportion of the population have complex needs. And the reason that's important to do is because different groups of the population need quite different services. People who are generally well, I think, tend to require less degree of continuity, perhaps less in the way of proactive care, but people who have complex needs require very high degrees of continuity. Often they require multidisciplinary teams, care plans, proactive care, responsive care with high degrees of continuity. Just the last couple of slides to bring it to life, as well as the 3x3 view of the population need, there's also a third dimension by virtue of the fact that people will have preventative needs, preventing them moving from the left of the diagram to the right, routine or ongoing needs other than the group who are generally well, and every group, whether you're generally well, long-term conditions or complex of any age, as we all know, as people working in the health system, people will have urgent care needs from time to time, irrespective of what cohort they're from. The best example I've got of how a primary care home has segmented their care according to the different needs of the population and streamed care is Lewis Primary Care Home in Sussex, who developed an acute care team and wellbeing team for those who are generally well, with call handling and clinical triage, a continuous care team, nurse-led for chronic disease management, whether that's multimorbidity clinics or single disease clinics, and then a really important team, a multidisciplinary team for the highly coordinated, personalised care of those with complex needs. I'll stop there, just a very quick but hopefully practical introduction to population health management, and hand over to my colleague Theo to bring this to life from a very practical perspective.
Great, thank you, Steve. We'll take questions at the end, but just waiting for Theo to come on board with his slides now. And really, really helpful to see actually how a population health matrix can be put into place. So hopefully now Theo will give us a practical example of that in his area. Okay, over to you, Theo.
Okay. Hello, everyone. Good afternoon. Thank you very much, Steve. I'm just waiting for my slides to come up on the screen. There we go. Okay, so just continue where Steve left off. So we were one of the primary care homes, second wave. We had the opportunity to work with Steve and his colleagues from NAPC a couple of years ago. And what I thought I'll do is in my few minutes, in the next few slides, show you sort of how we took the population health management approach and how we were able to put that into practice in developing services locally in our primary care network. So I like this quote by Emerson that you sort of need people who are willing to go with you on a journey. You need a few, you don't need everyone, but once you have a few people who are willing, you can get a lot done. Because doing something in a population health way is very, very different, like Steve was saying, from how we normally practice medicine. We're very used to a very disease-focused way of aligning our care. But when you start looking at the population health management approach, it's completely different and needs a very wide view of how you practice. So in our locality, we started as a primary care home 2 years ago, and we wanted to get a view of what our population health needs were. And to do that, we sort of decided to have an engagement event with lots of stakeholders across our patch. This included secondary care, we had community services, we had the local authority, but we also had voluntary sector organizations. We had our local enterprises in the locality as well who attended. And basically what we said to them was, look, we're looking at our whole population in the area. We wanted to try and find where there were gaps or needs that we needed to address. We wanted to understand how to help the population better with healthcare. And so we wanted to work with them. And it was interesting that every single partner was willing to contribute to that discussion and to help us with working out what and how to provide needs for people. So this is the 3x3 grid that Steve already showed you, the population health management grid, using the live courses as well as the level of complexity on the x-axis. And when we did our little sort of data gathering, we were able to populate this with lots of, we have got a slide with all the numbers as well, but I didn't put that into my slide pack today, but we decided to put down all these sorts of ideas and all the sorts of programs that we identified were either going on or could be developed for our patients or population in these different categories. And so that's sort of what it looks like. But then what we obviously did, and as I think it was Ben earlier on in his talk was saying, you can't sort of do everything as a sort of a primary care network or lead. You've got to sort of pick what you can focus on. And we decided to sort of narrow down and focus on just a couple of things. One thing I'll mention now is when you start looking at population health approach of managing care, what you very often find is that you identify gaps in service provision, or you identify needs that perhaps are sort of either have not been quite adequately funded or provided for, or just where the pathways are falling down. And that's what tends to come up really through your population health management approach when you look at all the data. So we decided to focus on a couple of areas. We looked at our children and young people. We wanted to do something that we thought, because we identified there was quite a bit of a gap and a need there, and something for the working age adults. And the area of focus that we came up with, that we wanted to narrow down to, was in mental health. There seemed to be quite a lot of emphasis on trying to support young people and the working age people with mental health provision. And the first one, we decided to work with one of our local private providers. They run a local gym, and we set up a program called Talk for Sport. And basically what this is an exercise-based activity program for young people, 11 to 18-year-olds, who have had some sort of mental health problem. And this range from anything from very low level sort of anxiety to quite sort of a little bit more complex, not quite the most complex cases, but certainly your sort of moderate depression or moderate anxiety levels as well. Another point I'll throw in here is it's very important when you're setting up a service, particularly in this way, you build in evaluation right at the very, very beginning. I think trying to do it later on always proves quite difficult. And I think in some of the services we've sort of developed in the NHS in the past, we don't quite evaluate them early enough or in quite the right way. So we decided to do an evaluation right at the very beginning of setting up this project, and we surveyed all the young people, found out how they were doing in terms of their mental health, in terms of their exercise and physical activity, and 1 in 7 young people generally across the UK do seem to have some sort of life satisfaction that's below average. In our survey, the young people that we surveyed scored themselves about 48% of their perfect or current mood being good. So that's sort of less than half thought they were in a good place emotionally. 72% of them were not meeting the necessary requirements for physical health for young people, and about half of them, or nearly half of them, had already been to see their GP with either depression or anxiety or some sort of mental health disorder. Nearly 3/4 had already been to a CAMHS service in the past. They went through an 8-week program with using physical activity and exercise as a basis. But part of the program included talks about nutrition, about mental health, mental resilience. They were building peer support, working in groups. So there was a bit of team working. And at the end of the 8 weeks, we sort of involved the school and their parents as well. And the findings from that showed that the current mood for these young people improved by about 16% just by going through this 8-week program. We found that all of them were now meeting their physical activity requirements. And from all those kids, when we were asked where they would rather have mental health sort of care in the future, nearly all of them wanted or preferred to have gone to a program like this rather than going to a healthcare professional in the traditional sense. So I guess there's something in there, some learning for us about how we deliver mental health provision or services to our young people, if majority of them would go through this and get a very significant improvement where they had perhaps not perceived such an improvement with going to the GP or going to CAMP services in the past. I'll just briefly talk about also the other thing we did was to talk to our local mental health community service and talk to them about providing IAPT in-house and in the practice. And I think for some people it sort of felt like we're just moving the location of IAPT from somewhere central to the practice. But in actual fact, what we found by doing this was that we were able to get a better engagement from our patients with IAPT, and so we were catching them early. We got better responses in terms of attendance, in terms of engagement with the service, and so the outcome and the outputs from our IAPT therapists working in the practice was slightly better than the average IAPT as well. We had less DNAs. And the other thing with working in this kind of way, because primary care home is all about working as a team, as a wider team around the locality, was also we found that we were able to upskill practice staff, so GPs and nurses, and even to some extent other members of the practice could walk down the corridor, talk to the IR therapist, get some advice. She's done training for our reception staff. We've been able to bring cases to a case discussion inside the practice. All of the things that make a big difference in terms of both individual care but also population health care for mental health for working with adults. And you couldn't really achieve those sorts of things with the traditional IAPT provision from a community mental health provider. What we're looking at now is trying to do the next phase of the service, which is trying to see how the IAPT therapist with her skills could be able to maybe help with some of the more on-the-day and sort of triage of patients that come to us on call, perhaps with mental health needs. And so we're just beginning to explore how maybe that could work with what we currently have. So I think we've just been able to use the information from population health management and been able to focus on two quite small but quite distinct projects. But the impact of those projects have actually quite surprised us, as well as the wider practice and the wider population in terms of how well they've been received and how much they've actually improved services for us. I think I'll probably stop there just so we have a bit of time for questions if there is any. Thank you very much.
Hi, thank you both. That was really helpful. Sometimes it feels as though there is so much to do and really difficult to be able to drum down into where to start and where to focus, because all of care feels so important. So really helpful to know that there are tools that we can use to try and focus our conversations. There have been a few questions that come in. Unfortunately, I think we've only got time for one, so I'm just going to read this out to you both to get your take on this. And the question that's come in says, is it true that interventions at the level of social determinants of health with impact on lifestyle and behaviour, bringing marginal left shift for individuals but significant population level benefit, have now been changed to high risk, big data driven and largely clinical interventions, which we now call population health management? What do you think?
Shall I just have a start of that? And okay, and I'll try to provide a bit of a response, mindful of the time on the text as well. I think it's a great question, and I think I probably see interventions at three levels. One level is the single individual patient level, which I think is traditional general practice and clinical care, where we can provide support both in terms of prevention, support, and maybe help address some of the determinants of health at an individual level, as well as clinical interventions when people have a particular need. We can then, I think, do much more at a cohort level, where we're looking at groups with single needs. And I think Teo's shown that really well in terms of young people who maybe haven't yet developed significant mental health problems but are identified as being at risk of doing so. And the intervention is preventative and early intervention, but it's not at a whole population level, it's at a cohort level. And then thirdly, there will be interventions that need to be done at a whole community level. And I think there is a danger of trying to say we should only do one or two of the three, and there's also a danger of conflating the three as well. So I think it's one of those both and answers, or whatever the right answer is when there's three things, not just two things. So how that been of some help? Teo, you could probably give a more practical answer to that.
Well, I think I would agree. I think it's I think you sort of we're quite well trained as GPs, I think, to do the individual sort of person type management. I think that's sort of what we do day in, day out. But I think when you, like I said at the beginning, when you start to look at the population health, it's actually, you do have to take a broader view and do a bit more targeted work. I suppose, I think, yeah, I like your description, Steve, about the three different levels, but I do agree, you do have to do both. You can't sort of focus too much on one or the other. You've got to do a bit of individual, but a bit of sort of population health at the same time, because I think what you're trying to do is to try and target people or try and catch people before they become more complex and sort of increase their level of complexity going along in their life journey. So you want to sort of try and put services in or put provision in to try and help stop people getting more long-term conditions or more complex issues in their lives. So I think yeah, it's how we do that is probably the art of it, and that's why I think we need to work in partnership. I think certainly doing this for the last couple of years, working with the people like yourself, working with public health and local authority, I think has been immensely valuable, because I think they bring some of that dimension into our discussions. We can bring a lot of the sort of personal into the discussion, but I think it's working in partnership really that makes it happen. But it's got to be a broad view.
A final thank you to all of our presenters today, who certainly have shown us the art of the possible, and I hope we can take away with us their energy and their enthusiasm into our own working practices. So do all of you who are on the webinar at the moment, do visit the website for more resources, do sign up to receive the regular newsletter, and if you've got any more questions, do send emails to any of us, gp@rcgp.org.uk, and additionally there have been some questions about additional support. So the RCGP have got a primary care development service that can certainly provide additional support tailored to your needs, so don't forget to have a look at them as well. And so to all of us and to all of you, all the best with your PCNs, and remember to enjoy the journey, and we and our patients will certainly flourish through the benefits of collaborative working.